Identify those things which you believe, and then let's talk about what options and alternatives there may be to those, or how to use a more purified version of those foods. I see diet in the context of the whole person. I see sleep, diet, exercise, lifestyle, being happy. People don't talk about that. We always talk about the comorbidities in migraine. And again, depression associates with obesity. So we tend to not look at things, we tend to be granular. The patient wants something that they can say, that's it. I know what's doing this. And so they do. They identify things like smoked meats, pickled foods, pizza is known, some vegetables. I have a patient who every time he eats green peppers, he gets a cluster headache, so he doesn't eat green peppers. I've had more than a large handful of patients who came back to me better saying, I cut out sugar. And just simply cut out sugar. And so I leave it to the patient oftentimes to make those decisions about what is compatible with the way they want to live. I think it's about taking time. The studies on communication in migraine really have centered around asking open-ended questions. Tell me what you think causes your headaches. And patients will typically have a lot of information about that. Sometimes they'll just say everything. And so then we have to kind of pull that apart. But I don't necessarily want you to ask them very specific questions to get to the answer. And that's what the communication studies have shown, that clinicians tend to want to fulfill the criteria for migraine. So they will ask directly, do you vomit with a headache? Does light bother you with a headache? I want the patient to give me that information. And if after 15 minutes, when I have a half an hour visit, I'm not getting anything except they're telling me stories about their cousin who had headaches and that their dog has headaches, I will ask them directly those questions so that I can come away with it. Or I'll use a form, which we do have at the clinic, that they fill out beforehand. So we kind of know what's going on anyway. But in terms of trying to make a diagnosis, that's what we're here for, you and I as clinicians. We're here to make a diagnosis. I think I also teach my residents and fellows and students that they want to take that voice out of their head and just be open to the questioning of the patient. And don't be afraid to ask hard questions. Don't be afraid to ask about trauma. Don't be afraid to ask about, again, dietary preferences. We need to be culturally sensitive in so many of the questions we ask. I recall a woman who didn't speak English. We have a population in my area of people from what used to be called Burma, Myanmar, who came as refugees. And I've seen several of them, and I have to be very aware that they may have belief systems about pain and about their brains and about themselves. And so after a year of seeing a woman who really was getting better, she brought me food. Okay, so there's your answer, is you really want to communicate with your patient, but gives them the opportunity to talk about what it's like. And then always end with the following question. Tell me, what is this doing to you? What is headache doing to your life? At that point, they cry, or they give me, they'll be very grateful, because it may be the first time that a clinician asks them not about whether they are bright lights or noise or smells, but really that I want to know what's going on in their family. What is migraine doing to their ability to be a spouse, to be a worker, to be a participant in sports, the kids who in school can't participate because of headaches, the adults who really monitor themselves to the point that they really won't do anything because they're afraid it will cause headache. So I want to identify the triggers in the context of their conversation with me. And then what I usually do at the end is to sit with them and say, this is what I heard. Tell me if I heard you correctly, so that next time you come back with calendars or an app data, we can then start to pick apart those things which you can do as a patient, or the patient can do actively without over-medicalizing their life. I don't want them to think of food as a poison. I don't want them to think of being outside as an obvious trigger. We need to work around some of that. And again, I come back to that because as a clinician, you need to be aware that the drugs are changing the landscape. And so patients are now beginning to come back 6 months into this new adventure with a whole class of drugs saying, I ate something I haven't eaten in 2 years and I didn't get a headache. What does that mean? And I go, I don't know what that means. It means that something's really changing in the way we're treating our patients. So trigger identification should be in the context of their life. I want them to be happy. That's really, maybe that's old school, but I think we're supposed to be happy people even if we're sick.